So any queries and questions you can post in the chat section. That will be subsequently answered. So yes, sir. So you can go ahead with the presentation.
Okay. Now I'm sharing my slides. I hope it's visible to everyone. So the idea was that as we have more and more transplants, that a lot of this care is transitioned to the general pulmonologist who initially saw these patients before transplant. So while it's important that the team of post-transplant follows these patients from the transplant perspective, a lot of the care is actually something that a general pulmonologist will eventually be called upon to shoulder, because when we have many patients, then a lot of it is pretty simple and straightforward. So, the idea was to basically make more awareness. So it's not something, and the share of care is usually determined with the individual pulmonologist. So some pulmonologists that I know who would like to manage most of it themselves with some help with the immunosuppression. Some pulmonologists do not want to be involved with this. So we usually discuss with the person who's referring so that we manage the care of the patient appropriately, making sure that no follow-up is lost. So, as a general beginning, transplant, if you look at lung transplant worldwide, the first successful transplant was done in 1983, which is one of the last solid organ transplants to be successfully done at Toronto. Even though the first transplant was done in the late 1960s for a patient with CA lung, that patient survived a very few days only after the transplant. So the first successful transplant, the patient actually went to survive 7.5 years after his transplant, and then died because of an unrelated complication. So we have gone a long way from that single lung transplant in 83. So you can see in 2017 to 19 now, we prior to COVID, we had roughly around 6,000 transplants a year, 80% of which is voluntarily reported to ISHLT every year. So most of it, as you can see from this diagram, there's an increasing tendency to do bilateral lung transplants as opposed to single lung transplants world over. Now, if you look at why there is so much talk about lung transplant in India, like I said, worldwide, this is something that happened late compared to other solid organ transplants. Similarly, in India, we are about 35 years behind the rest of the world. So the first successful lung transplant in India, the single lung transplant, was done only in 2012. And the first successful double lung transplant was done in 2013. So roughly even less than 10 years ago. And the program really only took off in India in 2017 as such. That is not heart lung transplants, but isolated single and bilateral lung transplants. Now, as opposed to this, if you look at the need for lung transplant, you can see that we actually have, this is data in 2016 compared to 2005. Among the top 5 causes of death, we have top 3 causes three causes among the top 5 are respiratory, that is COPD, respiratory tract infections, and tuberculosis. So if you look at COPD, it is the only cause among the top 5 which is actually increasing in incidence compared to the other causes. And India is now, it is number 2 as a cause of mortality. Respiratory disease is number 2 as a cause of mortality. And we lose every year more than 8 lakh patients to chronic respiratory diseases. And this is something that the public is not at all aware. And transplant as an option for several of these patients has not yet permeated in several pulmonology circles. So forget the general public. So this is, we need more awareness for these patients. And definitely, we contribute outsized amount of deaths compared to the respiratory disease burden. So this is something that we need to tackle as we go forward. And if you look at what are the transplant programs in India, essentially, there are only 2 states which are doing most of the transplants. So roughly about 60 per year in Tamil Nadu and 60 to 70 per year in Telangana. So, and there are 3 centers in Tamil Nadu offering this, and there are 2 centers in Telangana offering. Bangalore and Mumbai have recently started doing single-digit lung transplants. So they are also contributing, but not as such in a programmatic way. And if you look at the number of transplants in Tamil Nadu, we have 21 in this month, in the last 4 years. So on track to the 60 per year that we are doing. We definitely need to accelerate this with more awareness, and there is a need for at least 150 transplants per state to save several of these patients who are otherwise dying unnecessarily. And why would you say this? Because the survival after lung transplants has generally been increasing. So if you look at the median survival now, this is data which is 5 years ago. The median survival is well above 7.5 years now. And the conditional survival, that is, if you look at the survivors who of 1 year, you can expect most of these patients to be alive and doing well. 50% of the time, they are alive and doing well beyond 8 to 9 years, actually. So the conditional survival is pretty good. It's almost close to 10 years now. And changes are happening even as we speak in terms of prophylaxis and therapy. And data for India is not too bad. We are off by 5% to 10% only compared to international figures, and it's slow and it's quickly catching up. So if you look at our figures, if patients are selected at the right way in terms of the oxygen requirement, they're ambulatory on oxygen, and we'd expect them to survive 90% of the time at 1 year. And of those people who survive the 90% who do survive 1 year, we expect them to be alive 70% of the time in the next 5 years and 60% of the time over the next 10 years. So compared to liver, our numbers are not too bad off at 5 years, maybe 10% less at 10 years. So a lung transplant is not as bad as it is generally made out in the general public and general pulmonology circles. And even if among international data, if you look at this, there is a perception that a lot of these patients get repeatedly admitted. So this is data showing that it's not true. So if you look at people who are independent, you can see that more than 70% are independent and are able to join work. They're normal with minimal effort, and they're able to join work at the end of 1 year of a lung transplant. Certainly, we have several patients who are now joined their work and then completed degrees and taking care of the families at the end of 3 to 6 months after the lung transplant. So it's definitely possible. And there is another perception that the post-lung transplant patients need to get admitted again and again for either infection or rejection. This is data showing that that is not necessarily true. Even in the first year, less than 50% of patients actually need admission for infection or rejection. And more than 50% do not need any hospitalization at all. So in a normal lung transplant, what do you expect? So this is important to know what you can expect so that you can expect what is the deviation from normal, which is why, which is when our role becomes more important for a general pulmonologist. So this is a patient that we did the last month. There's a 48-year-old patient with no comorbidities, a non-smoker, had chronic ILD related to HP possibly, was diagnosed in 2019, was started on oxygen January 2020, just around the time COVID was starting. So follow-ups were lost at that time, not much spirometry done. Worsened symptoms over the next 6 months to 1 year. And by June 2021, functional status became pretty limited, was not able to go outside the house because of breathlessness, was referred for a lung transplant consideration, which they took next 6 months to really get convinced. So by December, workup was completed and listed. And then because of issues about his rehab and about his weight concerns, because his BMI is only 16, we insisted on some rehab and weight gain prior to transplant. So fully active only by February, and it took about 7 weeks for him to get an organ offer. When just before transplant, his BMI was 17, up from 15, that was baseline. He was on 4 to 5 liters oxygen and walked 300 meters after rehab, desaturating even on oxygen of on 8 liters to 65%. So this is his CT just before transplant. You can see the extensive lung disease, and even though spirometrically, so his lung volumes and follow-up looked pretty okay by 2021, but functionally his DLCO corresponding to this was 15% actually. So there was some issue in calibration, I suspect, which is why the numbers look better. And as you can see, he's a very tall guy. He's 185 centimeters. So this was the transplant done in drop on VA ECMO. You can see the new lungs in place. The arterial ECMO cannula, which was decannulated at the end of surgery. The new lungs looking perfused and really well. And this is the explant. You can see the extensive shrunken lungs with nodules. And you can see him. This is day 3 post-transplant, mobilized already. He's on some oxygen, and early tracheostomy was performed given his spoke off. And 1 episode of failed intubation to protect the lungs from aspiration. But otherwise, you can see he's doing pretty well, able to walk at 3 days post-transplant. Here, this is him. You can see him here at the end of 2 weeks nearly, where he's independent now, doing exercises against resistance. And you can see him here discharged, decannulated off the NG tube, looking ready to go at the end of 20 days, X-ray showing minimal bilateral symptoms, which is related to the sizing. for such a tall guy. Otherwise, pleural tab was not showing any infection. So how do we follow these patients? So typically, we follow these patients weekly after discharge, where we physically examine these patients. Of course, I'll be speaking about the PFT monitoring, but along with weekly, when we see the patients, we also do an X-ray. We also do PFTs every week, and then we do these tests, CBC, RFT, electrolytes because of tacrolimus, and we get a tacrolimus levels every week for the initial 4 to 6 weeks. And then once the 6 weeks are over, we have a bronchoscopy, which along with the imaging, along with these tests, and when we do surveillance lavages and transbronchial lung biopsies, and if there is no major evidence of any rejection, then these tests then become every second weekly till 3 months. And beyond the 3 months, these tests are then every monthly. When we follow these patients to 12 years, we do scheduled CTs and bronchoscopies at 3 months, 6 months, 9 months, and 12 months. So typically, we are able to discharge these patients from our care at the end of 3 months, where we ask the patients to go back to where they are from originally. So if they are from North India, they go back to North India. If they're local, then they follow up with us. If they are going back to their hometown, then we just follow them up at these 4 time points, and then they followed up for the rest of the time with their general pulmonologist. So they would still do every monthly blood tests, including the TAC levels. And beyond the 12 months, you can see the number of assessments are very few. So we follow these people 2 times for the second year, and then only every year, even though we'll be doing blood tests every 3 months lifelong. We do have some other tests like gastric emptying test and VH manometry, which we do once at 3 months. And tests for sensitization, including antibodies to the donor antigens, we do at fixed points. But what we expect from patients is that they would do these every day, especially in the first 3 to 6 months. So this is one of my patients who's done this religiously and then send these records. Most patients are not this religious, but we expect them to give us at the end of a week their FEV1 and this monitoring once every week. So this guy used to initially send it every day. Now has transitioned to every 5th day. But you can see you're doing quite consistently heart rates, oxygen saturation, FEV1 and FVC monitoring, and blood pressure. You can see the diastolic slightly on the higher side, so that was something that we asked him to monitor, which is important given the tacrolimus, and 50% of patients would require some antihypertensives during follow-up. So the role of transplant pulmonologist actually starts from POD 0. Follow-up is structured like I've shown. FEV1 typically will increase as the lungs expand, chest wall remodels after major surgery, and this FEV1 FVC will plateau by 9 to 12 months for the personal best of this patient. It is important to recognize this course other than a normal because we follow patients by FEV1 and FVC after a transplant. Most problems more than a week are actually general medicine problems rather than specific pulmonology problems. So if you look at what are the complications that can potentially occur after transplant, it's easy to look at this from a time-based perspective. So within 24 hours after transplant, the complications are primarily that of the complications that occurred in OT. So primarily, we put in several lines. We put in a PAC, central lines. We put patients are intubated. These are chest tubes, so they can all be malpositioned. So it's important to look at that. Sizing could be an issue. So size mismatch issues, which could lead to failure to close the chest. So or open chest is then we go in a couple of days later once the edema settles down to close the chest or to do a size reduction and close the chest. Postoperative bleeding and pre-exploration can happen 1 in 5 times. So that again may be an early complication. And very rarely, this is something that is virtually not seen in recent times, hyperacute rejection, which is because of sensitized patients. So it's important to screen these patients very carefully before transplant to avoid hyperacute rejection. After 24 hours to 1 week, the complications that we typically expect after the first 24 hours is primary graft dysfunction, which we'll talk about in the next few slides. Atrial tachyarrhythmias, especially atrial fibrillation, is very common. 1 in 2 patients will have, especially as we have an aged population to transplant. And it's often important to manage. We typically manage this with beta blockers. We'd like to avoid amiodarone, which is something that is associated with diffuse alveolar damage, organizing pneumonia, and a host of other lung problems. Pericarditis is another common complication after transplant because the atrial cuff requires opening the pericardium, and of course the ECMO lines as well. We also see pleural collections and phrenic nerve complications should ideally not occur, but could be there, and it's important to look out for these complications early transplant. And that will be typically evident as failure to wean because of diaphragmatic anastomotic dehiscence is something that will typically not occur so early unless there is a major issue, which is again something that we need to watch out. Systemic complications related to transfusion, infection become evident at this time of transplant, especially if there is something which is wrong, like severe PGD, etc. A rare complication is hyperammonemia related to transplant. It's important to recognize this. It's often idiopathic. We don't really know why this happens. There is no abnormality with the liver function test per se. Hyperammonemia occurs independently. So we screen for all hyperammonemia in all our patients who are not in normal sensorium after the first day for all transplants. There is a link with the Ureaplasma ureolaticum and Mycoplasma hominis. Roman really knows why this gets into the lung, but there is a hypothesis that BAL PCRs associated with this is independently associated with hyperammonemia, but not all patients which have been reported with hyperammonemia have isolated this on PCR. If there is a ABO compatible but not a mismatch, that is a O positive donor going into a positive or a B positive or a O positive, we can get something called a passenger lymphocyte syndrome. This will be manifested with severe hemolysis and anemia. That is typically something that presents at this point of time. Donor-derived infections, of course, are our most common problems around this time. In our setting, we screen all recipients for MRSA, VRE, and CRE. So we don't usually get recipient related because it's often prophylaxed appropriately. We usually get only donor-derived infections because that is something that the culture takes about 48 to 72 hours to come back. If, for example, the donor BAL cultures grow MRSA, typically even if you give prophylaxis, patients will have transient bacteremia, even though that is manageable after transplant. We also have a lot of donor-derived fungal infections. That is something that is unusual in the West, but very common in our settings because of aspergillus. So it's important to prophylax against that as well. Line-related infections and wound infections should be very few with good infection control issues. We always give prophylaxis for whatever bugs the recipient is colonized with, and this is especially important in patients with bronchiectasis. Beyond a week and after discharge, typically in the first month to 6 weeks, what is common is acute rejection, and again we'll be talking about this in the next few slides. Late onset nosocomial derived infections like candida.
Sorry to interrupt. Some of the participants feel the screen size, they are not able to see your screen. I mean, can you enlarge the screen?
My slide. Are you seeing that my slide is small, or because
I'm able to see, but some of the participants are saying they are not able to see these slides.
Slides are maximized. I cannot do anything more.
No, screen is coming small, and your the speaker is coming on the big screen. It's interchangeable.
It's the wrong screen, ma'am, because I'm sharing my screen and I'm not sharing my.
There is some problem with the settings that the screen is coming as small and the speaker screen is coming as a large screen. That's the problem.
I can put my video off. Maybe I can see if that helps. 1 second. All right. I hope this is now visible for most of.
Yes, perfect. Thank you so much. Yes. Okay.
So beyond the discharge, what is more common is acute rejection and late onset nosocomial infections. Typically, airway complications become prominent around this time. We typically give prophylaxis for pulmonary embolism till the time patients are admitted. So, if they are not as ambulant, then embolism can potentially become evident after around the time of discharge. Late onset atrial tachyarrhythmias are often again common. In specific complications can happen around this time, like hyperinflation. If you do a unilateral transplant for COPD, that can present with breathlessness with hyperinflation of the native lung. So apart from, but the typical complications at this time are typically rejection or infection. Beyond the first month, the infections are typically related to the community. And of course, rejection continues to be a problem till the end of the first year. Most means we'll talk about this again. Late onset airway complications, typically less than 6 months. It is always evident. Gastroparesis is another important side effect, especially related to lung transplant. So this is almost, it occurs in the tune of 50%. Almost recovers later on, but becomes a prominent problem in the initial period. This is because of the surgery itself, because of vagus nerve being stretched, because of all the medications which can cause gastroparesis as well. We often have patients who have prominent abdominal distension and abdominal pain, requiring admission if this is not tackled for management with prokinetics. So this is important. Of course, the other rare complications are early post-transplant of lymphoproliferative disease and native. If you do a single lung transplant, native lung complications are also there. Beyond the 6 months, complications are related to rejection, community-acquired infections, and the infections are typically the ones that occur when you stop the prophylaxis. So we typically, in a non-mismatch, give prophylaxis for CMV for 6 months. So when you stop, we typically go to CMV monitoring by PCR till the end of 1 year. So CMV viremia can become evident, and it's easily managed and not of any consequence if you monitor this carefully. Similarly, we continue, like I said, scheduled bronchoscopies, even though we stop prophylaxis for aspergillus at the end of 3 months. We do lavages and galactomannan at 6 months, 9 months, 12 months to monitor the galactomannan and treat accordingly for these patients, along with imaging. Drug-induced complications may become a problem if somebody is not aware of this and then administers some of these drugs to these patients. So it's important to be aware. As a pulmonologist, I try and avoid all of these drugs which can potentially cause lung-related complications and choose drugs which are not associated with these problems, especially nitrofurantoin, which is often prescribed for UTI in these patients. Beyond 12 months is when most of our issues are related to specific transplant-related issues significantly come down. So what is more important is late onset community-acquired respiratory viral infections, especially in seasons. So we typically had flu as a problem, RSV as a problem, but now COVID is something that is added to the list. We vaccinate for pneumonia typically prior to transplant, but then we also have several other bugs which can potentially cause pneumonia in these patients. So it's important to keep a watch out for tuberculosis, aspergillus, late onset, especially if the lung is not as healthy as it should be. Beyond 12 months, monitoring is very important to look for evidence of CLAD, and we'll be talking about this later. Long-term complications are typically metabolic in terms of diabetes, osteoporosis, which is again something that we monitor for this. Disease recurrence is almost never a significant problem post-lung transplant. The only disease which commonly recurs after transplant is sarcoidosis and almost never causes a functional problem in the graft. There are other specific diseases which can recur for which we watch out for. Often again, these don't cause significant problems post-lung transplant. Before we go on to I will focus myself on 5 specific issues post-lung transplant, which is of relevance to the general pulmonologist, rather than talking about everything which I talked about here. And then I can take about the rest as questions. Before I start talking about these 5 important things, I would like to speak about sizing, which is an important problem when you try to put lungs into the thoracic cavity, because like the brain, the volume in the thoracic cavity is fixed. So this is one of our patients, a 40-year-old male, B positive. He had COVID fibrosis. He was only 154 centimeters tall. His predicted total lung capacity according to his height was 5.2 liters. Clearly, this guy was, however, on 20 liters oxygen by NRBM intermittent with HFNC. So clearly, there's not a guy who you can do spirometry on, or you can get TLC on. You can see the X-ray here, significantly shrunken for somebody who's 154 centimeters related to his fibrosis. So this is a problem which is peculiar to patients with ILD and COVID fibrosis and COVID ARDS. So you have significant volume loss, which can happen very quickly. In this patient, it happened over a period of 3 months itself. So we knew going into a transplant that sizing is going to be a problem. So we choose somebody which is same size or smaller. So this was a female donor whose lung capacity will be, even at the same height, 10 to 15% smaller than this male guy. 154 centimeters, so 9 centimeters shorter than this patient, with only a PTLC of 3.78 liters. So actually you would expect going into the transplant that this would be an undersized lung for this guy. So this was the size that we measured before going into the transplant. You can see that it pretty much matches this patient going into transplant. However, when he got out the lungs, you can see that this lung is absolutely rock-like, not collapsing, but we still could not get the native lung in, the donor lung in, without size reduction of the lower lobe. So this is something that is crucial to have a plan while going into transplant, especially for patients with fibrosis. And even though we have several surrogates, the only surrogate is actually the X-ray size, which matches this patient's better than the other surrogates that we have. So let's talk about the first major complication after transplant. So this is a suppose which is deviating from normal. So this is a 47-year-old patient with a BMI of 32, was diagnosed with severe COVID in February 2021, was managed with HFNC, but became very acidotic and hypoxic, no other organ dysfunction, was intubated and thrown, managed with all the usual medications for COVID at that time. Severe hypoxemia, so was initiated on VV ECMO at 72 hours with a PF ratio of 55. So over the next 2 weeks, she was managed in a sedated, paralyzed manner, but there's no improvement in oxygenation or radiology at the end of 14 days. So she was managed transition to an awake ECMO strategy and spontaneous breathing with thermovent, which we managed to accomplish by 3rd week. However, she remained ECMO dependent at the end of 4th week with like you can see the flows here, complete dependence on the ECMO. The lungs were hardly doing 10 to 15 ml. Best case was 50 to 60 ml, I think, on the ventilator. So at this point, we decided to list her, to evaluate her for transplant really. So we evaluated her. She was only 148 centimeters. We did a right heart we did a angio, sorry, not right heart cath, because of the ECMO cannulae. We did only angio, and that was normal. Endoscopies were completed because of the risk of COVID, steroids, and molecular agents, newer agents, and Mucor. So endoscopies were completed and they were normal. CT chest and abdomen were done, which I'll show you in the next slide. She was CMV IgG positive. She required a lot of transfusion because of the ECMO. So there was some sensitization, which we knew about, and you can see her sickness score. So LAS is typically, this is the lung allocation score, which is used in US to allocate donor pools. We don't use it in India, but we use it as a surrogate of illness severity and waitlist mortality. So typically our LAS scores are 35 to 37 when we list patients. So the higher the LAS score, the higher the transplant benefit, but also a very high association with waitlist mortality. So if you have somebody more than 50, the expectation that they will die over the next 3 months is very, very high. Clearly, this is a guy on ECMO, or this is a lady on ECMO who's not going anywhere. So, and the risk of mortality is very high over the next 3 months. So we did get a prospective donor by the end of 7th week, I think, after on ECMO. So we did a virtual cross match. You can see that we matched this for the A. So this patient had antibodies against A2. So we took a donor who's A24 and on both alleles. And CDC also was negative. Because of significant size issues, she had to undergo bilobar transplant. That is the right middle lobe and lower lobe on the right side, and the left lower lobe alone on the left side. Despite taking because as you can see, somebody who's 148 centimeters and with COVID, we needed a pediatric donor, which really was not happening at this point. She was ABO matched, and this was done on VA ECMO. You can see this patient undergoing awake ECMO, fully oriented, and doing physio. At the end of 4 weeks of ECMO, you can see the lungs at the end of 5 weeks completely consolidated with air bronchograms, and this is the X-ray. I close to about 7 weeks with complete dependence on ECMO. So we did this with standard induction, immunosuppression, antibiotics, and semi prophylaxis and voriconazole prophylaxis. Surgery as such was uneventful. Converted the VA to peripheral VA because of RV dysfunction. As you can see, when these lungs go out and then the new lungs come in, all the resistance to flow disappears, and the RV now is able to pump all the blood into the LV, which is then unable to cope up with all this blood flowing into it. So we typically give VA peripheral support for about some time, 2 to 3 days, for the LV and RV to cope up. So you can see this. This is the introp surgery done on VA ECMO. This is the explanted lungs, completely consolidated. And this is on POD1. What you can see is bilateral mid-zone infiltrates. While we continued on VA ECMO and a lung protective strategy. So bronchoscopy showed bilateral anastomosis was pretty good, and cultures were all negative at this point, both the donor and the recipient. At 72 hours, what we noticed was the right upper lobe infiltrates worsen. So when you get a unilateral infiltrate, one was concerned about pulmonary vein stenosis or occlusion at that time. So we got a TE done, which showed all the pulmonary veins were okay, and EF was okay, wedge pressure was okay. So this is the opacity at 72 hours. A CT clearly showed that there was a extrapleural collection, but also there are air bronchograms also available. So this is the lung window. You can see that the lung is not fully expanded. There is a hematoma, which is apical at this point, related to the some bleeder here. So this patient had to go for re-exploration and clear that. But what is also seen is there are infiltrates with some crazy behaving in the underlying parenchyma. Once this was cleared, you can see the X-ray here. Looking very nice. Some pleural, effusion and small component related to size on the right side, and small collection in the mediastinum on the hilar side on the right side. But other than at this point, this patient is off the ECMO. All the cannulae are off. You can see the patient tracheostomy, but off the ventilator here. So clot evacuation done. ECMO was the VA was off at day 5. VV was off at day 8. Slowly mobilized off ventilator by the next 4 weeks. This is another extreme example of primary graft dysfunction. You can see this. So there was again a COVID transplant. Sizing is an issue, and then you can see the chest is open here because of sizing issues. But over the next 72 hours, PGD has set in related to the transfusion during surgery and the host factors, because most of these patients are on ECMO, have bacteremias and are generally sick and in inflammatory state. So what is primary graft dysfunction? Primary graft dysfunction is essentially the syndrome of ARDS after transplant, and it occurs in 20 to 30% in a significant manner. About 2 to 3% require ECMO after transplant for support of the lungs while this graft dysfunction settles down. PGD is typically scored at 4 time points: T0, 24, 48, and 72 hours after a transplant. The diagnosis is made based on X-ray showing features consistent with ARDS and a PF ratio showing a ratio less than 300, similar to the ARDS criteria. While diagnosing PGD, it's important to rule out airway occlusion due to tubes, vascular obstruction, like I pointed out, volume overload, cardiac issues, transfusion-related ARDS, rejection in sensitized patients, and aspiration. So what are the risk factors for PGD? You can see that several of these factors are non-modifiable. Like, for example, we have several donor factors which are potentially modifiable, but several of these recipient factors are non-modifiable. Right? For example, prior surgery and prior pleurodesis, which is primarily linked to PGD because of more blood transfusion, increasing BMI, which we try to modify. These are some of the modifiable risk factors. But there are some unmodifiable risk factors like the type of disease and pulmonary hypertension, which independently is associated with PGD. Donor factors, the only factor which is consistently linked with PGD is donor smoking, which is again something we ask for in every donor call. So there is no single mechanism for PGD. It is just the lung, it's a ischemia reperfusion injury, and it's a combination of mechanical, immune, inflammatory, and possible microbial factors. When the lung comes out from the ice and then goes into the patient after reperfusion. Like I said, if you look at PGD, there is a significant link with mortality. Those without PGD, the first year mortality is actually less than 5%. For those with PGD, the first year mortality is about 11 to 15%. And even long term, there is a link with CLAD and PGD. So it's important to look for factors associated with PGD prior to transplant to optimize some of these factors before. Management is often conservative. We try and match donor recipient combinations. We don't match a bad donor, marginal donor with a marginal patient. We match a good donor with a marginal patient to offset the risk for PGD. If we have a patient who has some risk factors for PGD and who's not getting good donor calls, then there is a role for EVLP to avoid high-risk donors. EVLP is extravascular lung perfusion, which will help us optimize lungs prior to going in onto the patient per se. So that is PGD. We then go to the next complication that we can talk about. This is another patient of mine, a 37-year-old patient with scleroderma ILD with a UIP pattern, on home oxygen for 1 year before I saw her with worsening oxygen requirements, unable to do PFT for the last 2 years and not able to take care of her children. No transfusions, but married with 2 children and some sensitization with several antibodies, which are listed here. So she had DRB1, DRB14 and B4 antibodies. Last, as you can see, because of a worsening, was more than what we would usually like. No significant pulmonary hypertension, mild to moderate pulmonary hypertension. Endoscopies and esophagus was pretty normal. So we decided to go ahead transplant. We got a prospective in-house donor. Because of the sensitization issue, we prefer to take in-house donors for these patients because we're able to do virtual cross match only on these patients. So we avoided, this thing. We had information about DRB1 and DRB4. So this DRB was DRB1 and DRB1404, but not 1401. So this was a virtual cross match negative, and CDC was again negative. So we were able to do this off pump bilaterally. And you can see this transplant UIB pattern going into the transplant. You can see this lungs, post-transplant tubes bilaterally in and looking pretty okay. Good, was extubated on, I think, day 2 here, managed with standard immunosuppression and prophylaxis. She was, however, on day 7, she had new onset infiltrates bilaterally. Counts were normal. Bronchoscopy was pretty okay. Bile cultures and blood cultures were negative at this time. Echo was normal LV. There was no significant pericardial effusion, and she did not have improvement with diuresis. So she was quickly intubated for worsening pulmonary infiltrates. So at this point, there was a doubt about her, what was the cause of these bilateral infiltrates with this thing. So this is typically the time when we have rejection. So we also looked at her. So this is the HLA of the donor, of the recipient, and this is the HLA of the donor. So if you look at, we typically get the high resolution HLA around the 7th to 10th day, which is when this information became available. So if you look at the baseline sensitization of these patients, so this patient had DRB1 and DRB1 10, 1401, and some DQ antibodies, none of which were a match for the donor. So when this patient became reintubated, we repeated a SAB to see if she had developed any new antibodies. But lo and behold, at this point, we had a DRB1 1404, which is what the donor had at this point. And this, so when we went and cross-checked the initial SAB, this SAB did not include this particular antigen at all, which is a peculiar problem in India because of the HLA distribution in our population. So we were having this sample, we reran the sample, and then we were able to show that the MFI for the 1404 was significantly high here compared to this baseline. So this was a patient with a acute antibody mediated rejection with some overlap with cellular rejection. So we managed with the Plex, pulse methylprednisolone, IVIG, and 3 mg per ATG, given that she underwent some basiliximab induction instead of 5 mg per kg. So you can see the X-rays here serially got better, and you can see the antibodies at which were repeated after discharge at the 7th month here, showing that the antibodies are completely disappeared. So she was managed with a high immunosuppression strategy because of her AMR, but that was complicated by an episode of E. coli sepsis, for which she was treated and discharged. And this is the X-ray at 7 months when she did well. So acute rejection. So that's the next complication that we are going to talk about. So acute rejection is a possibility in somebody with previously stable lung functions and an acute decline in their FEV1. The differential diagnosis for rejection, of course, is always infection, an airway complication, extrapulmonary causes due to heart failure or fluid accumulation due to kidney or liver disease, effusions, or a pneumothorax, and drug-related complications. If it's a single lung disease or a recurrent primary disease, theoretically, is a potential differential diagnosis. So we always rule out these when we consider acute rejection as a possibility. How common is acute rejection? So historically, if you look at data, it's around 30% in the first year of the historical data for acute rejection. As our immunosuppression has improved, the incidence of acute rejection has significantly fallen. For example, in 1995, you could see that the incidence of acute rejection was around 30%, and that has fallen off significantly at around the 1-year mark. And the risk factors were significantly HLA mismatching and the development of de novo DSAs and a younger age. These were the risk factors for an acute rejection. Of course, CMV mismatch and CMV viremia is also independently related to rejection. If you look at the current data, and this is data from the Toronto cohort, which does 250 lungs per year, you can see that the incidence of acute rejection, which is A1 and A2 put together, is now less than 10%. And this is in 2019. For 2020, these figures were less than 8%. So as the immunosuppression has improved, the rejection component has now dropped toward significant rejections have dropped to 8 to 10% with the current strategy. So how do you diagnose rejection? Rejection, ACR is typically diagnosed on TBLBs. So TBLB, we have a grade of rejection based on the finding. The primary finding is perivascular mononuclear infiltrates, which is primarily lymphocytic infiltrates. And based on the severity of this perivascular infiltrates, involvement of the septum, we classify this into grade 1 to 4, with higher grades associated with worsen outcomes and more clad. Again, we also look at grade something called the B grade, which is based on the airway inflammation, the inflammation surrounding the bronchioles, which is seen on the TBLB, if you're able to see them. So this is the A grade. You can see the inflammation around the blood vessel here, a single cell or 2 cell thick here, which is again brought out nicely by this stain, GMS stain. And you can see there's more infiltration around the blood vessel with more than a single layer. So significant A2 rejection. This is spilling out to the septa now. So you can see this is the A3 rejection. And if there is DAD with some hyaline membranes here, this is A4 rejection. If you have a single cell inflammation without epithelial inflammation here, it's B1. If you have epithelium which is damaged, it's B2. B2 is more linked to clad than A grade rejection, which is of course also per se independent related to clad. This is AMR, on the other hand, is related to a pre-existing or a de novo DSA, which is a donor-specific antibody. If you have donor-specific antibody, there is no one histopathological feature that is associated with the rejection. You can have diffuse alveolar damage, you can have capillaritis, you can have organizing pneumonia, or you can have acute fibrinizing organizing pneumonia. All of these pathological features can be present. Complement 4 deposition is again something that is classical. So you require typically a DSA. You require histopathology, C4D deposition, and ruling out other causes, which I talked about earlier, in the presence of alveolar dysfunction to label somebody as having a definite AMR. The confidence of diagnosis of AMR is a problem in the lung as opposed to kidney. And the more you have these features, the more confident you can be for managing these patients. We go on to the third complication. This is a 33-year-old male with silicosis, significant fibrosis on home oxygen, with increasing breathlessness, married with 2 children, no transfusions, was no significant PAH, was last of only 37, was managed. Since he had no antibodies, his virtual cross match was negative. We didn't actually do the donor short low resolution HLA. He was ventilated the donor was ventilated for 5 days. This was done off pump, extubated on POD2, mobilized off oxygen by POD4, doing really well, was managed with standard immunosuppression. So went to the ward, was walking around. We did a surveillance bronchoscopy before discharge on the 2nd week. And lo and behold, this was the bronchoscopy. So bear in mind, this was somebody who was walking around without oxygen. I will fast forward this in the interest of time. So you can see this, the right anastomosis here, full of muck and black with epithelial necrosis, completely occluding the right side, a lot of muck here, similar findings on the right side. So required really a lot of clearing and lavage, and underlying epithelium looked fairly okay. The bowel smear showed aspergillus flavors and galactomannan was high. So this was some early donor related. By the time we had got the donor related reports as well. So this was a donor aspergillus, which was affecting the recipient, despite the voriconazole prophylaxis that this patient was on. And you can see here, he improved with therapy, but there was a dehiscence which required placing a stent and a bronchomalacia on the left side, requiring a metal stent on that side. So extensive mucosal ischemia necrosis was debrided and managed with repeated bronchoscopies, voriconazole and amphotericin. As you can see the airways here, significant improvement except one small area of dehiscence, which is requiring so this is the right side, requiring a silicone stent placement here, left side in Malaysia requiring a metal stent there. On follow-up, doing well off oxygen. You can see the X-ray here, some left-sided infiltrates, but otherwise well at 5 months with the FeO2 from 1.5 liters. So airway complications are again something that is pretty common. Mild complications can be expected 20 to 30% of the time, requiring no to minimal interventions. As significant airway complications like this patient occur less than 2 to 3% of the time. And we can have several complications. We can have ischemia or necrosis like the one I showed. You can have dehiscence like the one again I showed. You can have stenosis, which can be related to both the anastomosis and non-anastomosis. Anastomotic stenosis are very understandable. The anastomosis becomes narrow, requiring balloon dilatation. Say, for example, while anastomotic stenosis is here, again, here you can see the right upper lobe opening here. This is the anastomosis, which is mildly sphenoid, less than 50%. This is the upper lobe which is seen. What I'm trying to point out here is a non-anastomotic stenosis. So when you cross the anastomosis already, we are going into the intermediate bronchus. What I'm trying to show is the middle lobe opening and the lower lobe opening. So this is the lower lobe basal segment, and what was seen earlier, that is the apical of the lower lobe. What is not seen, what is the pinch is seen, that is the middle lobe opening. So that's a complete non-anastomotic right middle lobe occlusion post-transplant. This is often due to reperfusion injury and preservation issues. Of course, Malaysia is something that can occur due to post-infection sequelae, like for example, the patient that I showed, often managed symptomatically or with stenting is very severe and causing dynamic occlusion. So that is the airway complication. So we go on to the next thing that we need to discuss after lung transplant, which is infection. Infection is something that is part and parcel of lung transplant because of the nature of the transplant. So we'll talk about the same case. So this is the patient here. Another thing before going on to infection, I'd like to point out. So this is the dehiscence on the right side. Corresponding to this, the CT, you can see an extra bronchial air pocket here, which is again nicely showing the dehiscence, which required a silicone stent on this side. So this patient still doing well, quite well at 6 months with FeV1 of 1.65 liters without oxygen. When he had this left lingular consolidation that we showed you, because he was undergoing repeated bronchoscopies, he had several lavages done, and galactomannan was being followed because it was initially 5.4. So that was negative at this point. So the consolidation was not very clear because the bile cultures were also negative, and we gave empiric antibiotics orally initially, then subsequently IV antibiotics, not better. You can see the left lingular infiltrates, which is worsened over 1 month period, almost giving rise to a reverse halo sign. So we were worried about mucor because he was on voriconazole at this point. Fortunately, we did not have mucor, but what we had was this particular organism, which was picked up by our microbiologist. A lot of thanks to her for picking this up. So you can see this rhabdiform lava very nicely here. So diagnosis of strongyloidosis is made. Strongyloidosis is something that we almost always give prophylaxis prior to transplant. So this is a patient, we always give ivermectin 2 doses prior to transplant. So this patient had got 1 dose, but had skipped the 2nd dose, which is possibly why he had such a late onset strongyloidosis. If you are going to have strongyloidosis after lung transplant, it's typically hyperinfection immediate post-transplant when it presents with bilateral infiltrates and the ARDS-like syndrome. So also with this, the infiltrates were also because of some Klebsiella, which grew subsequently. So both of this was managed, and you can see that significant clearance has happened at the end of management for this. Able to remove the right stent and the left stent with some 40% Malaysia. So left the left stent in. This is another patient, I'm sure, just for discussion's sake, from Toronto, a 47-year-old male who's now 6 years post-transplant, developed a drop in FeV1 to 20%. At this point, developed cough, and at the 7th year had bilateral lung infiltrates following an episode of community acquired respiratory infection related to RSV. FeV1 at this time was 55% with an obstructive pattern suggesting a Boss type clad at this point. You can see the lung volumes are preserved. DLC is only 60% of predicted. CT I'll show now. So we managed this Boss type clad with azithromycin, but there was no significant improvement in her FeV1. But she had worsening cough and dyspnea at 8 months follow-up. So this is the X-ray at this time. Apart from the mosaic findings, what was evident was a cavity in the right upper lobe. So a repeat BAL was done, and that isolated mycobacterial abscesses. So if you have clad, that's a risk factor for NTM. And that is what we isolated at this point. So she had progressive drop in FeV1 related to this. So she was started on oxygen and triple immunosuppressive triple therapy for M abscesses. She did lose weight related to all the imipenem and tigecycline that she was getting, but her FeV1 stabilized a bit. And then she was aggressively managed in terms of nutrition and then relisted for transplant once her M abscesses downgraded with therapy. And because most of the lungs are out, all the lungs are out, the old lungs are out when she was relisted, there was a significant debulking with M abscesses, and we were able to cure her M abscesses after the retransplant, which she underwent successfully. So infections post-lung transplant are part and parcel because of high levels of immunosuppression. Lung is among the organs with the highest level of immunosuppression required because of the amount of BALT, means lymphocytic tissue in the lung. And we also have a variety of donor risk factors because our patients are all intubated with risk factors for several MDR pathogens in our environment. Recipients have received multiple courses of antibiotics, especially the patients with bronchiectasis. So they have selected MDR pathogens, and the lung after transplant is constantly exposed to all sorts of pathogens once in the community as well. So we give, because of all this, we are very, very, very fussy about our vaccination and prophylaxis. So the presentation, of course, depends on what is the load, and that is in relation to what is the patient's immunity and the preemptive therapy that, or the prophylaxis that we give to these patients. So there is a timeline after lung transplant. So in the first 1 month, what is usual is the community-acquired what is usual is the nosocomial infections that occurs. So we typically screen the recipient for MRSA, VRE, and CRE in our setting. So what is usually there is the is all these pathogens from the donor, which again we do blood culture, urine culture, BAL for all pathogens in all of our donor calls. Of course, line-related infections and uncommon donor infections. But what is common in a setting is Aspergillus, and very, very uncommon mucor. We again look for all of these during the donor round. Beyond the first month, what is common is depending on the prophylaxis. So typically, while traditionally some of these infections are reported, this is significantly modified by the prophylaxis that we give. So what is more relevant in our setting is this. So we typically give prophylaxis with valganciclovir in a knot mismatch for 6 months, voriconazole for 3 months, and Cetera lifelong. So we only get nosocomial infections related to the donor call lines in the first 3 months. In the rare instance, we also get Aspergillus like uncommon in the first month. In the first, beyond the first month to 12 months, we continue the Valgan prophylaxis. So CMV can occur once we stop, but we often monitor for CMV viremia for the first month. We again monitor for Aspergillus by surveillance BAL. So this is again pretty uncommon beyond the first month, beyond the first month to 12 years. So what is more common after the first 12 months is when the prophylaxis goes off, is community-acquired respiratory viral infections and pneumonia, infection with mold, especially if there is some clad, late onset NTM infections. These are the ones which are common after transplant. And we base our diagnosis based on the pattern on radiology in combination with the time scale that we have shown previously. Especially if there's ground glassing, then apart from infections, AMR, ACR, drug toxicity, diffuse alveolar damage, organizing pneumonia, alveolar hemorrhage, and clad are differential diagnoses which we should consider for these patients. So we optimize patients prior to transplant by several serological tests to vaccinate these patients and to decide on prophylaxis. Like I said, we screen all our recipients using some of these tests, MRSA, VRE, and CRE swabs. We do a donor BAL and blood and urine culture on all of these donor calls that we have. We vaccinate these patients and give ivermectin and albendazole for all our patients. We also optimize the immunosuppression, not on one particular number, but based on the net level of immunosuppression and the risk for infections based on some of these factors that we have discussed. We routinely recommend our patients to avoid some of these dietary foods that we would like them to avoid. In our setting, it's important that they avoid street foods and continue annual vaccinations and prophylaxis as recommended. So that is about infections. We then go on to the fourth and the fifth last thing that I would like to talk. So just about to finish in a few minutes. So this is a 23-year-old with Cepacia negative CF, cystic fibrosis at Toronto, who is now roughly 3 years, 1 month after his transplant. At this point, he had significant gastroparesis, which vomited several of his tacrolimus pills. So probably some compliance issue there related to his gastroparesis. He presented with dyspnea and new onset DSA. So when we speak about DSAs, this is how this is usually. So this is the patient's HLA profile. A 16 loci HLA is available, and this is the donor HLA loci. So you can see at baseline, this patient had no donor-specific antibodies at all. But around the time when he had this breathlessness, you can see a new antibody appearing, that is DQ5, DQA456. So what is this? So you go here and look at this DQ. This is the DQ locus, and you look at what is the donor locus. The donor is 0, 1 at one locus and 0, 5 at the other locus, which is what this antibody is against. So this antibody is called a donor-specific antibody. This is directed against the alpha chain of DQ, DQ05, and the beta chain is again sorry, I was trying to point to this. DQA is this. DQA is 0.5. This is 4, 5, 6. So 5 is a donor specific antibody. And if you look at DQ5, this, when you mention DQ5, means the beta chain. So DQ beta is DQ5, and there is DQ beta. Again, this DQ beta is DQ5. One of the alleles is DQ5. So both of these are DSAs in this patient. So if you look at the single antigen bead, this is how it will be reported as. These are the positive tests. So DQA505 and DQ5 are DSAs. Now, the reason why 4, 5, 6 are positive is because they share some eplets. And so there is cross-reactive antibody between these three antigens. So that is why 4, 5, 6 are positive. But nevertheless, in this patient, the positive antibody is the DQA5. And you can see the corresponding CT, bilateral ground glassing with mosaic appearance related to chronic AMR and CLAD in this patient. So CLAD, when you speak about CLAD is a substantial and persistent decline in measured FEV1 more than 20% from the baseline. The baseline is computed as the mean of the best 2 post-operative FEV1s, which are taken 3 weeks apart. If you look at how the ISHCT now classifies CLAD based on this criteria. It classifies the severity of CLAD based on the cutoffs that we use, similar to the COPD cutoffs that we use. So when we have a FEV1 decline of less than 10%, that is when we think that CLAD is likely. So we really aggressively evaluate this patient. We rule out infections, we rule out ACR, we rule out AMR, we rule out airway complications and extrapulmonary complications, which can contribute to the FEV1 fall over the next couple of weeks. However, despite all this, if the FEV1 continues to be lower than baseline, then we call this possible CLAD. We can only call this definite CLAD if, despite your intervention, FEV1 is more than 20% lower than baseline at 3 months. We classify CLAD based on spirometry, total lung capacity, and CT as Boss type CLAD, RAS type CLAD, mixed type CLAD, and undefined CLAD. And how do you classify this in the next slide? So this is one pictographic appearance. This is from the cladilometer available at Toronto. Just to show you the pictograph. So this is the best FEV1 and best FVC that this patient had. And you can see here, baseline FEV1 is shown in black and red. These are the best values. And this is the best FVC. This need not be on the same spirometry. This is all the PFTs that this patient has done over time. And compared to that, the baseline FEV1, which is 20% lower, is taken. Similarly, the baseline FVC, which is 20% lower, is taken. In this case, a line is drawn. Once this patient is now beyond this, less than 20% for more than 3 months, then this is the point at which we can label the patient as CLAD. CLAD onset date is the first date when which the FEV1 is less than 20% of the baseline, not 3 months. So that is also important. So how common is CLAD? CLAD is a function of time. 50% will have CLAD at the end of 5 years, but does not mean that all of them will have respiratory failure. So very significant minority of this will require, will be in respiratory failure. They'll just have, let's say the baseline was 2.5 liters. If the FEV1 is 2 liters now, then it can be labeled as CLAD. But 2 liters does not mean you will be on oxygen. It only means your lung function is lower. So what is important is the trajectory rather than your absolute value. Of course, there are several other things that we should consider when we label somebody as CLAD, and these are some of the important factors. You can look at this when you have more time. And again, this is how we classify patients as having Boss type CLAD and RAS type CLAD. It's important because they are independently related to the trajectory of lung function decline and prognosis. So to summarize, lung transplant is a life-saving intervention. Complications can occur after lung transplant, but can be prevented and treated in the vast majority of patients. In India, we have to specifically focus on infection issues, and the intensity of immunosuppression is very important. It's not one number, but it's a dynamic number. The intersection with pulmonary tuberculosis may be significant as we have more patients undergoing transplant. So the data scan at the best means to prevent and screen is not very clear. We use quantiferon and prophylax all our patients if the quantiferon is positive for the first 9 months. Because with INH, because we cannot use rifampicin after transplant with tacrolimus. Due diligence is needed to diagnose patients' complications early to prevent CLAD in these patients. Thanks to all the team members at Kaveri and Sparsh who make this activity possible, and for Nityanandan for hosting this session. Thank you.
Thank you, sir, for an excellent talk and a comprehensive review of the real cases which you have done. So, any questions from the participants?
Good morning, sir. So just wanted to ask you, so this HLA, what you had mentioned there, so you mentioned that some of the HLA patterns are not done, was not done in one of the cases there. So does, doing the HLA patterns around India, all over India, does it matter or does it differ for each regions also?
So a very good question, Hari. So, and it's very relevant with especially ongoing patients that we have. So no, HLA, I didn't mean HLA. What I meant was a single antigen bead. So when we speak about, virtual cross match, you're speaking about the donor HLA, but the recipient's antibody, right? This is what you're speaking about. Speak about a virtual cross match. So the donor, we always do the recipient HLA also, because when there might be some antibodies which are autoantibodies, they are functionally irrelevant. You cannot have antibodies against your own HLA, right? And live right. So we will remove that. So to remove that from the calculation, we do the recipient HLA. But what is important is the donor HLA. So at baseline, we would get a donor HLA in all our patients, but we will also have a single antigen bead of the recipient. The single antigen bead is basically a panel of antibodies tested by a testing called a Luminex assay. So what it does is it will look for antibodies specific to a particular HLA allele. So obviously there are hundreds and thousands of HLA alleles. So you cannot screen for all known HLAs. What you can screen for is 99 HLAs in one panel. So that is what is usually done. There are two commercially available screen tools which is available, which all the labs will do. So you have to speak to the lab to know what their lab is using. Usually what is available is a 1 lambda or a immunocore. Most labs will choose the 1 lambda panel. That is the single antigen bead panel. Now, if they choose the 1 lambda panel, it's important to know that this panel is being chosen based on what is the HLA distribution in North America, not in India. So it is possible, very possible, because of the HLA spread in our subcontinent is totally different from North America. Our HLA frequencies are totally different from what is in North America. The antibodies that are being tested might be missed here. So if it is missed, it's important for you, once you get the donor HLA, to cross-check that the single antigen bead includes the donor HLA. And if it's not, to retest it using a different panel. So that is what I meant. The HLA cannot be missed at all. What can be missed is if you don't test all the alleles. So I showed you all the 16 alleles that we need to test. So commonly we do A, B, C, DR, B1, DQA, DQB, DPB. These are the alleles that we do. So we do 14 instead of 15. We don't do DPA in India, that because it's not available in India. But HLA, if you do all of these, we should be able to catch most of these patients. I hope that answered your question.
Thank you. Thank you, Dr. Srinivas.
One more question from Dr. Kiran. So here asked, could you describe once more the interpretation of HLA?
Yeah, I hope I hope that was clarified. So HLA as such is less of a problem. So the antibodies is more of a problem, right? So and then the antibody interpretation is a whole separate thing. It really requires experts. So you need it's not something that is a readout like say sodium or potassium. You need to talk with the lab. You need to see the pattern, and there are so many things called correct patterns which we need to look at to interpret a particular value. It's not that you got a value, it's important. So there is no particular MFI which is significant. You can have a low level antibody, but it can be high affinity. So even at a low level antibody, you can have, and the test that we do is an optical density test. So it is not a quantitative test. It is a semi-quantitative test. So it's important to realize that the MFI that they represent is not a milligram per deciliter. It's like ODI. So for galactomannan. So it's an optical density readout. So it's an entirely total different world actually, and I do not claim to be an expert in this. So every time we have a patient, you just go back to all your correct patterns and then look at it, and if you cannot make sense out of it, speak to the expert. I usually call my friends at Toronto to because they have the immense experience they have, but it's important to set up local contacts as well. Yeah.
One more question from Dr. Sumit Agrawal. She had asked, Do we consider single lung transplantation or invariably we'll do double lung nowadays? That's what she asked.
Oh, excellent question. Sorry, I didn't go into that part at all because I was only focusing on the post-transplant follow-up. So see, there are some instances in which you can only do a double lung transplant. So the indications for that will be if patient has cystic fibrosis or bronchiectasis, because you don't want the transplanted lung to be soiled by the native lung. So say you have bronchiectasis bilaterally, you have lung abscess on one side with a lot of fibrosis bilaterally. Those are the indications for doing a bilateral lung transplant. Now, the other indication for doing bilateral lung transplant is significant pulmonary hypertension, because you cannot have one lung with pulmonary hypertension and normal ventilation and the other lung with normal vascular bed and ventilation, because ventilation will go uniformly, but perfusion will be different depending on the resistance. So if you have significant moderate to severe PH, it's an indication for bilateral lung transplant in most of the sectors. The third indication for doing bilateral lung transplant is very young people. So you have people who are less than 50 years due to any indication, then that becomes, say, COPD, ILD, any indication, it becomes an indication, because by doing bilateral, you're giving them more lung, more reserve against future clad. And then more functional improvement. So that is why in young people, we prefer a bilateral, and there is a mortality benefit in patients with ILD, especially those who are young. Now, COPD patients are a problem because especially if they have significant bullae on one lung. You could do a single lung, but if they have significant bullae, then you can have native lung hyperinflation after transplant. So that would be a relative indication, especially if they are younger, to do a bilateral. But in most other instances, you could get away by doing a single lung. So you have a 65-year-old ILD patient, there is no need to do a bilateral lung transplant. You don't do a bilateral kidney transplant for these patients. All you do is a single kidney. Similarly, all you need is a single lung transplant to keep these patients alive for the next 10 years. I hope that answered that question.
Yes, sir.
Yeah, okay. Thank you very much. Yeah, thanks.
Dr. Arjun Bhatnagar asked, can you brief the process of referring patient and listing patient?
Oh, very good question. So and very relevant, I guess. So referring patient is very, very simple. So I will, 1 second, if you can, I'd like to show something. Bring this up. So I hope my number I will share. If anyone wants to refer, that should not be the rate. So if you just able to reach me and discuss any case at any point, that is the easiest way to to refer a patient. But of course, there are several ways of doing it. So I will show you one way. Is my slide visible now?
No, sir, we are not able to see.
Okay, 1 second. Let me. Yeah, got it. So I guess yes, it should be visible now. So the other one. Sorry. So yeah, so this is how we would encourage you to. So my number is here. For those of you who don't have my number, please note this down. Or you can alternately reach my coordinator. His number is as well here. So what we usually do is for patients who are able to walk independently with oxygen and who are likely to survive the next 3 months, then this is when you should consider transplant. We don't want you to be considering transplant for somebody who's on the ventilator, somebody who's on ECMO. That's not Hello.
Sir, sir.
Sorry. Okay. I think I got disconnected. I hope I'm audible now. So what we usually do is we do a Zoom call if the patient is out of station or the patient in person. Then we typically admit the patient for a workup, pre-transplant workup, in which they essentially meet everybody in the team. We identify what are the problems with transplant into this patient. And then we list this patient once these discussions are over, patient is willing for a transplant and the workup is complete. Once the part of the requirement for listing these patients is they should be able to relocate for 3 months to the transplant center. We operate out of Kaveri, Chennai, and then we have another center at Splash, Bangalore. So we are able to give the choice between these two cities for most of our patients. While the patient is relocated, this involves 1 month waiting for a transplant and 2 months after a transplant. The patient is actually doing rehabilitation while waiting for a transplant. The transplant is typically ambulatory, so we call the patient whenever an organ now becomes available for transplant. Transplant surgery typically takes 8 to 10 hours, depending on if it's bilateral, 4 hours if it's unilateral. We are able to discharge most of our patients by the end of 2 to 3 weeks. We typically follow up the patients every weekly, like I've showed you beginning, and then at the specific time points, except those time points, patients go back to their primary physician, and this is the cost that we are primarily involved in transplant. I hope that kind of clarifies the most of had. Or maybe I didn't share my slides. Oh my god. Okay. Does anyone have Nityanandam? Does anyone have any questions? Sorry. Am I audible and visible? Sorry. Nityanandam, are you able to hear me?
Sorry for the brief interruption because of some technical glitches. Yes, sir, you can continue.
So Ayushman Bharat does not cover transplant because it has a limit of 5 lakhs. Like I've shown you, the cost of a transplant is 25 lakhs to 30 lakhs actually for the transplant, and then 5 lakhs for the first year. Beyond the first year, the average cost of medication is 4,000 per month. So it's actually cheaper than most chronic respiratory diseases for your patient beyond the first year. CM scheme in Tamil Nadu is able to offset our costs by 20 lakhs, which is possible. We have a set of criteria for patients in which we are able to take in CM scheme, which we have evolved based on our bad experiences. So I guess Ayushman Bharat does not cover transplant. Any other questions?
So I don't see any more questions. So I myself have one question, sir. If a patient has been referred from like an outside center, like how are the logistics being arranged, and how long should the patient stay in the city after transplant?
Yes. So
how is the follow-up being done with so much frequent investigations being necessary?
So Nityanandam, this is I don't know. I tried to project this earlier. I don't know if this is seen. Can you see the slide? How to access lung transplant for your patients?
Yes, sir. Fine.
Okay, so this is what I was talking about. So when you have a patient from outside the state, what we try and see is how sick they are. If they are actually ambulatory on oxygen, then we ask them to come commercial flight. AirAsia, Indigo are able to pre-book oxygen, and then you can come by that. Another option is to come by train ambulance. So these are the two options for patients to reach Chennai and Bangalore. At the workup, I've already discussed. The workup typically is admitted and will cost around 2.5 lakhs, which is not covered in the package. Once they are listed, it will take 3 months for them to stay here. So and most of the time is in the pre-transplant period is only in rehab. So there's not much cost except the cost of staying in Chennai and the expenses in Chennai. We are able to arrange accommodation within half a kilometer of the hospital. We have centers, we have oxygen delivery, and we are able to help with most day-to-day requirements for patients. So all thanks to the excellent support from Kaveri Hospitals. Beyond the transplant, after discharge 3 weeks to 3 months, we still require patients to remain locally and do tests only once a week. So all of these are, we have helps from companies which patients are getting medications. So a lot of the costs are offset that way. So like I said, the first year will still take 5 lakhs for prophylaxis and CT follow-ups and otherwise. But beyond the first year, the cost should be less than 4,000 per month.
Okay, fine. That completes. So, are we seeing any more questions? I don't see any more questions. So, can you call it up, sir?
Yeah, I think so. Yeah, if everybody's happy.
Okay, thank you everyone for taking part in such a nice session. And I thank Dr. Srinivas for such an excellent presentation. And so hope to see again another excellent webinar.
Thank you.
Thank you.